Thank you, Brian. It's an absolute pleasure to be, I'm very much, as you know, associated with ISQua, but it's an absolute pleasure to be talking in this excellent series. Well, excellent to date. I hope to continue that excellence on critical thinking. So, you know, Eric has spoken already, Eric Holnagel, at the first lecture on critical thinking, and he put the case that what we were interested in this series wasn't critical crisis planning. It wasn't getting organized for critical crisis, but we thought we'd concentrate on critical crisis thinking. And Eric Holnagel set the scene in the first lecture, and then Gary Klein, a world expert in decision-making, and quite famous for his work on naturalistic decision-making, followed up with the next lecture. I'm going to use that as a platform and take that forward and think about, well, what actually happens cognitively when we are thinking as a crisis develops and then deepens. And I'm going to concentrate on, well, what about, can we predict with confidence, or can we even have confidence as a crisis develops, as we think through what we need to do? So I'm from the Australian Institute of Health Innovation. That's my day job when I'm not doing ISQua stuff and other stuff. And we do health systems research. We're very interested in providing research to underpin improved health systems. And you can go to our website and get lots of our papers and books and summaries of our work. I'll draw on some of that as I go through this lecture. So the faculty has, my faculty at Macquarie University has its logo, its mission, which is heal, learn and discover. And I spend most of my time in the discovery area, trying to get new knowledge into the hands of policymakers, managers, leaders, clinicians, politicians, patients, patient advocates. So there's three centres in our institute. I run one of them and I'm the director of the institute. Enrico Carrera is a doctor who became a health informatician, and he's interested in health informatics and artificial intelligence, that sort of space. Joanna Westbrook's an epidemiologist. She's interested in safe systems of work, including in aged care, medication safety, and creating safer workplaces. We've got 3 university centres that we each run, and then we've got a whole lot of other centres that we get funded from externally, from places like our National Health and Medical Research Council. So if you want to talk to us at any stage about your own research or compare notes with us, you're most welcome to do so. So crises. Well, Eric set up the argument about crises, and I'm going to take that further forward, bearing in mind what Gary Klein said. So, you know, crises just happen upon us, and they always challenge the readiness and resources of our organisations. People essentially are trying to find out, when a crisis comes upon them and then deepens, what the situation actually is. But in fact, there's no real actual is, there's just lots of different perspectives on what's going on. So the kinds of questions that we'd like to ask a priori before we even think any further is, what predictions can be made and how are they made, and by whom and when? And I just want to put in brackets here, often predictions are made after the event by people saying, I knew this was going to happen. That's not the sort of critical crisis thinking we're interested in. And I'll come back to that. We're also interested in what the responses or reactions to various things that we will do to combat the crisis or deal with it. And those reactions will come from all sorts of different angles. And then what could the unexpected reactions be, things that we don't anticipate, if you like, the unknown unknowns that come upon us. So those are the things we're going to be dealing with. Now, you can't really talk about crisis today without thinking about the pandemic that we have going on right now. And I will return to this, but one of the things that's of interest is how much policy has arisen to deal with the pandemic after it has really well and truly become entrenched. And we've done some research already, which we're going to be publishing in due course in the next few weeks, we hope, which asked which countries were actually prepared pre-pandemically for COVID-19? Which ones had a plan? Which ones were on a good footing? And then we're asking in this research, which I'm going to draw on later, did they actually take notice of their own planning? Did people do good critical crisis thinking? Or did that all go out of the window? And if that's the case, why? And can we avoid that happening in the future? So that's by way of introduction. So let me go into part one and talk a bit about what do we do when we do critical crisis thinking? Are we essentially in our heads just muddling through? Or are we, the rational planning bit in our head, planning out what to do next? And of course, it's a mixture, but let's have a look at both of those features of the human brain. So Charles Lindblom, wrote a couple of famous papers in 1959 and 1979. One was called The Science of Muddling Through, and the other one was Still Muddling, Not Yet Through. In fact, we're just producing another book in our Resilient Healthcare series, the 6th book. And if you've followed that series a little bit and our work on resilient healthcare and safety too, you'll be no doubt pleased to know we're going to use Lindblom's idea of muddling through, that most of the time people in organizations, in health systems, everywhere, spend a lot of time just getting by, just muddling through, finessing and doing workarounds to get to the other side of their day, week, month, job, career. So muddling is used to describe coping with constraints and opportunities that come upon us. It describes the practice decisions that we make on the spot, in the situation we're in that very moment. It has lots of associated names. Muddling, of course, is a bit pejorative. It's like, what? It's all you can do, muddle through. Lindblom didn't mean that, and we don't mean that. It's actually, we're using that as a technical term for people maneuvering, doing incremental things to get by to the next stage in whatever they're handling at the moment, whether it's a pandemic or clinical practice. There's something called satisficing, which Herb Simon made famous and got a Nobel Prize for. It's also about gradualism, adaptive actions, taking baby steps, having degrees of maneuverability in your work, and it's sort of evolutionary rather than revolutionary in its time frame. So that's muddling through. Now, typical working conditions in healthcare actually show that what we do is spend a lot of time muddling through. So people don't spend their time when they come across a problem going to the policy manual, taking it off the shelf and saying, oh, I can't go to this meeting unless I've read all the policy on whatever the meeting's about, finance. Instead, healthcare, which we all know, of course, we who work in healthcare or research healthcare settings, is an open system where what happens in the surroundings can never be neglected or taken for granted. Healthcare settings, ecosystems, are complex systems where outcomes emerge and come upon us rather than us dictating all the time that they're going to emerge the way we want them to. There are always unanticipated problems and challenges. We can't ever completely prepare in advance. And resilient performance, which we've published 6 books on to date and lots of papers, relies on continual adjustment for people and teams to incrementally satisfy their functional goals, say to treat patients or run a unit or whatever it is that they're involved with. So muddling isn't used pejoratively, sort of sneeringly to say, oh, you're the sort of person who just muddles through. Muddling is actually a technical term which helps us understand how often our very productive behaviours are enacted in complex workplaces that are ambiguous, deceptive, sometimes chaotic, and always uncertain, because that's what characterises healthcare. So resilience is another bit to this jigsaw puzzle. And resilience, the normal meanings of resilience, the meanings people have in their heads, are when we prevent something bad from happening, on our ability to prevent something bad from becoming worse, or the ability to recover from something bad once it's happened. We're more sophisticated than that. We don't see resilience as something necessarily about individuals, although you can take that view, and psychologists do. We see resilience as the performance of the system, It's almost a property or a characteristic of the system. So for Hollnagel, a system's resilient if it can adjust its functioning prior to, during, or following changes, disturbances, opportunities, not just crises, and thereby sustain required operations under both expected and unexpected conditions. And that's what we want for healthcare and other sectors when a crisis comes on us. So resilient performance is quick to respond. It's adaptive rather than just tough. It's not just, I'm resilient, I'm tough. It's more adaptive. It's about monitoring the situation that you encounter. It's built into the DNA of the organization and it's baked in. It's about workarounds and heuristics, finding shortcuts and ways to get things done. And it's about improvisation, flexibility, and our capacity to maneuver in complex settings. So that's by way of introduction. I now want to go on to talk about specifically individuals and their decision-making when crisis comes upon us and what they do about predicting what to do next. So this is about cognition and sense-making as predictive models. So Kahneman summarized an awful lot of psychology and his partner Tversky, who unfortunately died, and therefore Kahneman got the Nobel Prize without Tversky, although he dedicated half of it to Tversky. They were two psychologists, two Israeli psychologists who've been working in psychology for many years, looking at how do people do things and how do they think about things cognitively. So many of you will have read some of this, and if you haven't, I do say to you, go and have a look if you like this sort of stuff at his book, Thinking Fast and Slow. It's fantastic. It's a summary of all his work in this area. So system one, he says, is the part of cognition that is fast, intuitive, instinctive. It's skillful behavior when people are experienced. For example, physicians who can sum up all their experience in an instant and accurately diagnose a disease at a glance. It's the part of your brain that detects hostility in a voice when someone speaks to you, even if it's a little bit of hostility. And it allows people to effortlessly complete things like the phrase bread and butter. So it's kind of like you don't have to do anything to get system one thinking. It happens to you as you go through life. System two is the correlate of that, the reciprocal. It's slow thinking. It's deliberate, reasoned, logical, effortful. It demands your attention. You have to think to do system two thinking. Examples are when we park a car in a narrow parking space, or fill out a form, or decide to change careers. You really have to reflect on that, almost write some stuff down about the pros and cons. So these are the two brains that are running inside your head. System one deals with things automatically before you even know you're thinking that or making that decision. System two, where you have to calculate and work out and deliberately reason. So system one and system two are with you. You don't have to do anything about these, although many people do courses on formal decision making and how to read an academic paper, an article, to sharpen their system two thinking. But you get both really for free. This is part of what the brain does. And when system one encounters something not easily understood, it's sort of system one, you've got that always on, and you encounter a problem, it's unexpected, then system one calls on system two to make sense of the irregularity. Now that's when a crisis hits, you automatically want to do stuff. You automatically think, I know what to do. Instinctually, or intuitively, you say to yourself, I'm going to tackle it this way. System two kicks in when the crisis occurs and says, hang on, we need to think this through. We need to get a few other people involved. We need to have a chat about this. Now, the only other cognitive stuff I want to platform this rest of this talk with is the idea of Carl Weick and sense-making. And Weick, this is really linked work, although Weick's a social psychologist and Kahneman and Tversky were sort of individual psychologists. So he wrote this famous book in '95 called Sense-Making in Organizations. And what he was basically saying was, you know, everybody spends a lot of time working out what's going on in the organization. Who's doing what to whom? What are the people up there doing? What's my team doing? What's the culture like? And what patients are coming in that need to be treated urgently? All that sort of stuff. So we're always doing sense making. And he has these principles, which I won't go into because I want to get to somewhere else in this talk. But it's well worth thinking about how Wyke has said how much we spend time sense making, making sense of our surroundings in the complex organizations we work and research in and do policy in and lead. So we are always sense making, and we are always striving to do resilience, to be resilient in complex healthcare organizations. That's my summary to date. But note I've also put into the mix a new word, which is complex. One of the problems in patient safety and quality of care and healthcare generally is there's a number of people in any organization or any setting who kind of try to deal with things in a mechanistic kind of linear way. They kind of want to ignore the complexity and say, let's just issue more policy and we will apply that policy to the organization, to the people on the front lines, to the managers and leaders, and that will get us out of trouble. It'll make care safer and it will improve the quality of care. If you think that way, and I'm sure no one associated with any of the work that we've been doing or with ISQua would think that way, you're really backing the wrong horse in the wrong race, because we've tried that for many decades to produce more linear solutions to complex problems. And really, we've got the healthcare system we have today, which doesn't produce often all the things we would like it to produce. So we've done a lot of work on this, on complexity science in healthcare, taking the position that, you know, just having a linear solution, let's issue more policy, let's mandate a role for someone, let's insist they do something a certain way, let's absolutely say you have to 100% follow the guideline. And we've said, you know, you might have to do that sometimes, that might be useful, but just thickening the rule book is not going to make care safer or enable you to deal with a complex problem or a critical crisis. So this is a download. It's a freebie. You can go to our white paper on complexity science in healthcare. It's on our website and in many other places on Google, and download it. If you like that idea that you have to navigate the complexity rather than just think that you can issue a linear instruction and expect everybody in a chain to carry that out. Because humans aren't like that, are they? So, having established that, the notion of resilience, the way people think, the way they sense make, the way they, if you like, naturally react in thinking mode, in two modes to crises, and that's the source of their critical thinking. I want to go on to 3 case studies before we have a chat and tease some of this out. So this is courtesy of my colleague, Robin Clay-Williams. Thank you, Robin, who did a bit of work a couple of years ago on this thunderstorm asthma problem that hit Australia, hit Melbourne in Australia a couple of years ago. So we're going to use the resilience assessment grid, some more of Eric Holnagel's work and the Resilient Healthcare Net, which has used this a lot, which is a way of assessing what's happening in your organization and looking at the resilient performance of your organization. So Eric has 4 bits to this: the ability to learn, the ability to respond, the ability to anticipate, and the ability to monitor. And he sees these, and many people have followed him in this, sees these as good ways to assess the situation in your organization and look at its resilience, its resilient performance. So just keep that in mind, and I'll return to that shortly. So in 2016, in November, which is coming up to the summer in Australia, over 2 days, 10,000 people presented at hospital with breathing difficulties and 9 died in Melbourne, Australia. The precipitation for this was a thunderstorm. And the conditions were interesting. It was the second wettest September on record. There was high pollen levels. It was spring coming into summer in Melbourne. There was a particular pollen which was something that elicits a lot of hay fever and an allergic response. But usually the pollen grains from this pollen are too large to enter a person's lower airways. But November 21 was unusually hot, and by 5 p.m. it was still 34.4 degrees, and there was a strong wind blowing. So the pollen grains got sucked up into the warm atmosphere, absorbed the moisture, blew up, and fine pollen grains now were able to settle back to Earth and enter people's lower airways. So this is the mechanism by which this occurred when there was a big thunderstorm, and it created this very unusual situation where all the pollen was ruptured, and there were tiny pollen grains all over the place, all over Melbourne. So this is a chart of the daily ICU admissions in Australia in 2016, and the spike was the November spike. This was published in the Lancet's Planetary Health Journal. Here's the total number of ambulance in Victoria, where Melbourne is, the state that Melbourne is, by hour for this period. Here's the hourly presentations to 2 major hospital emergency departments when all this was going on. So you can see this is a crisis, completely abnormal compared to normal events. This is the age and sex distribution of asthma-related hospital admissions, and this is the admissions by hour across the day. And here's the hourly respiratory presentations to all of Victoria public hospital emergency departments. So you can see there's a rush on. This is a crisis. So if we think about the anticipation, one of the 4 resilience assessment grids, despite the thunderstorm forecast, there wasn't really any anticipation of an impending emergency. People, in our language, for the purpose of this course, this program, people hadn't started to do critical crisis thinking yet. The clinicians recognized a phenomenon of thunderstorm-induced asthma, but there was no way to communicate this widely, even when it started to come on and the patient started to arrive. So the state communication systems weren't suited to rapid onset problems like this. So Monitor is another one of the 4 resilience assessment grids ideas on the grid. And the idea is, can you monitor as things go along, as the crisis kicks in and then deepens? So during the thunderstorm asthma event, there were leading indicators, a surge in demand for telecommunications, ambulance and hospital services. So as these were being monitored, it was possible to discern that a big problem was not only coming, it was now impending and it was now happening. Respond, despite the rapid onset, emergency services then kicked in really well in Melbourne and responded very quickly and very, very fast. They leveraged and increased the scale of their respective operations. Although there wasn't as much anticipation as people would like, and maybe the monitoring wasn't quite as good as people would like it to be, and it's easy in hindsight to know that, people really responded very well. The 4th aspect of the resilience assessment grid is learn, and the state government created 16 recommendations related to improving data and information systems so that it would be better next time at critical crisis thinking and have more information at their fingertips. And there was an intra-agency working group established to share knowledge and improve procedures. So they knew they couldn't do anything about this. This was in the past, but they were then preparing for future eventualities. My second case study is the Australian bushfires. It seems like a lifetime ago, but it was only this year, late last year and early this year, that the Australian bushfires were amongst the most terrifying of events. And the whole world was looking at the Australian bushfires and thinking, this looks like Armageddon. It was so bad. And yet this has faded a bit because we've had COVID-19 and the pandemic. since late January, first case diagnosed on 31st of December, by the way, just to jog your memory. And we've had the pandemic to deal with for the last 6 months. So the bushfires seem like a strange, eerie, distant memory. But actually, they're very recent. It was only 9 months ago that this was terrifying. So the Australian bushfires of 2019 to 2020 were literally the worst bushfires in our history, and they were exceptional in size and impact. They were called unprecedented and by far Australia's costliest natural disaster. It began in the September, which is the springtime. They burnt 19.4 million hectares, larger than the Amazon and California fires combined. I know we like to see international competition, but that's not a competition you want to win. Firefighters were fighting a fire at one point about 6,000 kilometres long. Now, just for a reference point, Europe from north to south, the most northerly to the most southerly point, is 5,297 kilometres. That was the front that firefighters were trying to tackle in Australia. There were 33 deaths, over 3,000 homes destroyed, 19,000 farmers, fishers and foresters were impacted. It's estimated over 1 billion animals died in the bushfires. Huge numbers of species were majorly affected, and these are unique species. Australia's fauna and flora is pretty unique. And the tourism industry lost a lot of money. So a number of people attribute this to climate change. I certainly do. I've seen lots of the data in Science and Nature on rising temperatures and its effects. If you believe the science about COVID-19, I think you've got to believe the science about climate change. New South Wales had its warmest January to August period before this. There was a decline in rainfall, average rainfall's falling. Australia's the driest continent, and there's low soil moisture. Climate change has been lengthening the fire seasons each year, year on year, and therefore there's less time to do controlled burns of the environment. So the challenges before this were that there had been funding cuts in the rural fire services and to fire and rescue. And in hindsight, it's easy to do critical crisis thinking in hindsight, but that was crazy in hindsight, especially with lengthening fire seasons. We need to put more resources into the firefighting capability, not less. As a result of these fires, one example is the Victorian government. It has put a lot of money into affected communities, put millions into getting rid of buildings that are just falling down because they've been burnt apart. Big rescue package for wildlife and tourism. This is only one of our state governments. And a $64 million package to help fire-affected communities. There's a big bushfire community fund, and it's estimated that $500 million, $500 million has been put in by private individuals and charities. And there's a new bushfire agency in Victoria, the Bushfire Recovery Agency, and they've had lots and lots of disaster management inquiries and handed down over 1,300 recommendations. That's all words. If you want a picture, this is what it looks like. This is not normal. This is not even the new normal. We don't know where climate change and escalating bushfire risk is going to take us. But this is very difficult. So now is the time for Australia. It is doing a lot of this, but now is the time for critical crisis thinking. We don't need big lengthy plans, hundreds of pages, big policy manuals that you can't jump over, that people use to prop up their computer laptop. What we need is much more critical crisis thinking about this kind of pandemic and this kind of bushfire problem, and we need good information early so we can anticipate and predict what is likely to happen based on all the information available to us. Final case study, the third case study, and then I'll finish on time, Brian, because I know you insisted I finish on time, which will give us time for some questions and Q&A. You can't do critical crisis thinking without drawing down on what we're going through right now, COVID-19. So let me use that as my third case study example, and then I'll finish with a little bit of data. So you can pick any 4 countries My research group is doing an awful lot of work, and we're publishing a number of papers on how prepared people were, and whether they thought they had enough PPE, and how the communication structures were, and the extent to which people had a plan already before COVID-19 and the pandemic hit, and what they did with that, and whether they usefully used it. And if you even read the papers or Google the news, there's lots of examples of countries that did relatively well and countries that have not done as well. All I can say is thank goodness for WHO and other organizations that ISQua works with, and the cool, collected demeanor they've had during this whole crisis. They haven't got everything right, but boy, have they been a good resource for many, many countries, lots of whom don't have much in the way of resources and yet are trying to tackle COVID-19. So let me really talk about 4 countries. I've just sampled 4 countries, but it could be any number of countries. Australia, which I know well, even though I spent a lot of time traveling and with ISQua in Dublin. This is the country I live and work in. It's got an advanced health system, and really it's a lucky country. It's got good resources by which to tackle crises. You can also look at Thailand, which has a population of 70 million. It's a developing economy, a universal healthcare system, providing essential healthcare services to all Thai citizens, and it's done relatively well. Sweden, which took a different model. My Swedish colleagues often say that they are pleased with the way Sweden handled the pandemic, but some people have compared the Sweden outcomes to Norway and Denmark, adjoining countries, where they had fewer cases and fewer deaths, and didn't close, but closed down and did stringency, whereas Sweden did stringency but didn't close its economy down as much. And it too has a universal health system. And the 4th case is New Zealand, which has also done very well. It took a different tack again and tried to completely mitigate and stop altogether the pandemic in its country. So Australia took steps to form a national cabinet, primed the economy with lots of resources for people who no longer had a job to stay with some level of support, a salary. Put lots of money, $2 billion, into funding telehealth, increased testing and tracing, and fast-tracking increases in capacity for the workforce and resources to tackle the pandemic. Redirection of services, elective surgery was put on hold, private hospital wards closed, and they were held in reserve for the future pandemic that we expected. And it didn't really come as much as we expected. Australia was fortunate and worked well with critical crisis thinking in the pandemic. There was clear communication too, and guidance, and mandatory quarantine for returning travellers. One of the fortunate aspects of Australia is we can close the borders because we are an island continent. We're a country on a continent all on our own. And we can close the borders much more easily than you can, say, if you're a country in Africa or South America or Asia or Europe. Thailand, they took early notice of the pandemic. The first case was detected early in the pandemic. They did sophisticated airport screening of flights arriving from China. A state of emergency was declared quite early or briskly compared to some other countries. They had an army of health force volunteers who were trained and sent to rural areas to educate people on hand hygiene and physical distancing. So they kind of sent the message out about stringency. Volunteers helped triage cases. They prioritized testing, and they tried to dispel rumors and misinformation, which we know always happens during a pandemic, during a crisis. People get the wrong idea, or there's a lot of exchange of strange ideas that don't necessarily follow the science. The cultural practice of wearing masks for colds and flus, which the Thai people already did, assisted to control the slow spread of the virus. Thailand employed systems developed and refined with SARS and MERS, and took notice of that experience and brought that in to the way they tackled the pandemic. And they had some early missteps. Who didn't? What country did this perfectly? especially then later got communication and consistency of message sorted out. Sweden did some things differently and is a very interesting case for people who do crisis management courses, and I've been following the pandemic closely. It's a very interesting case. They took a much softer approach than the other Scandinavian, Nordic countries. No hard lockdowns, no insistence of stringency, more asking the population to take responsibility themselves. And that's the sort of Swedish way my Swedish colleagues tell me, and those people I know who observe Swedish culture. The Public Health Agency argued not for lockdowns and that they would work only temporarily and would be too ineffective to justify the impact on the people and the economy. So that they relied heavily on the sensibility of Swedish citizens to do the right thing. And there's a strong streak in Swedish culture on that. High schools and universities were closed down, but under 16-year-olds were encouraged to attend school to continue their education. Work from home was encouraged, but not mandated the way it was in some countries where lockdown was mandated. Outdoor gatherings, bigger outdoor gatherings were banned, but cafes, restaurants, bars and nightclubs remained open for seated patrons through the pandemic. And people over 70 years were encouraged to stay home. So that's a different approach and is an interesting experiment, in fact, if you look at the world and the different way countries tackle this, which we're studying. We're studying 40 countries at the moment and how they tackle the pandemic. It's an interesting case study. And then New Zealand, at one point, didn't have a case for, I think it was 100 days. So they'd suppressed totally and got rid of the virus from their community, from the 6 million people in New Zealand. So they were aggressive, responded to the pandemic early and clearly stated they were not just doing suppression, but they wanted to get rid of COVID-19. The government's advisory panel was urged to go hard, go early, and they did that. Despite no deaths and only 205 active cases, which most countries would say is almost suppression, they closed their borders to non-nationals and did mandatory quarantining for all returning nationals, their own citizens, mobile testing units, only essential stores, pharmacy, grocery, and fuel, gas and petrol were allowed to open. Work from home was ordered. Non-essential travel banned. Limited outdoor activity except for exercise and shopping. And social interaction was limited to only within households. So a completely different approach, trying to get rid of the virus altogether from the community. So what's the current status? Well, this is as at now. These are the deaths for those different countries. And these are the confirmed cases. And this is the world at the end. These are the people who've recovered. These are the active cases. And this is the population for each of these countries. So I've chosen 4. But to be frank, you could choose any 4. And we're doing work on this. We're having other webinars outside of this one on different countries' reactions to the COVID-19 pandemic, because there's so much to learn. Now, I'm going to start to wind up and finish. I just want to give a little bit of data, and then we can take, Brian, time for Q&A. So this is research not yet published with ISQua, my own research institute, the Australian Institute of Health Innovation, and also our Italian colleagues in the Italian Patient Safety Network, Riccardo Tattaglia, and colleagues. So this is a joint project of Australia, Italy, led by Italy, Australia, and ISQua. So we're going to publish this later. These data are totally confidential, and this is just between us. I'm not going to tell you the whole data. I'm only going to give you sort of a sample, an idea. We had 1,100 survey responses from 97 countries. Most said they had an effective plan at the time we surveyed them in sort of June-ish. Most said they had established a task force. Most said they reported testing frequently, their population. Most now had PPE, personal protective equipment. But all responses differed across the WHO regions. So some WHO regions, we analyze this at the level not of countries, but regions, and there are different responses to different WHO regions. So that's a flavour for where we are now, or at least about 4 weeks ago when we stopped this survey, when we paused the survey and started to analyse the data. We're going to publish this paper, Ricardo, myself, Peter Luckman, and other people in the Italian group and the Australian group, we hope in a few weeks' time. So that gives a feeling for what the world is up to now. Most have got the things in place they need in place to tackle the pandemic, as at a few weeks ago, up to a couple of months ago. But that's confidential. So I'm supposed to take Q&A now, but in closing, I would like you to think of a couple of things. One is, what do you think now about being able to do a couple of things? One is, after 3 lectures in this series, think through before an unknown crisis hits. What do you think now about how you're going to think and what you're going to think about? And then what do you think about your capacity to be able to predict with confidence when, how, and where the next crisis will emerge? Because we know one thing absolutely surely. We know there's going to be another crisis. We know there's going to be another pandemic after this one. So, Brian, I'm opening things up for discussion, comments, and questions, and for people to make observations if they wish. I would like to, in closing, firstly, just give a wave from some of the team that work with Enrico Coira, Joanna Westbrook, and I in the Australian Institute of Health Innovation, a wave from them to the people on this call. Just to make a few acknowledgements of some of the groups that work with me and the fantastic work they do, and I've drawn on some of this. So thank you to my teams. And then an acknowledgement of the thunderstorm asthma slides from Robin and the background research and preparation of the other slides from some of my research team. If you're interested in the kind of books that I and the Resilient Healthcare Net and other colleagues around the world, many of whom will be on the call, contribute to, here's the published books that I've contributed to in the last few years. They're all available. And here's some forthcoming books that I'm working on. Because, I'd hate to run out of work. And then finally, if you want to get hold of me, I've left on the end of the slides details of how to read more if you like this stuff and if you are interested in patient safety, implementation science, health reform across the world. This is how to get hold of me, and I'm happy to answer questions. So, Brian, that's the end of the slides. I think we can broaden this out to a Q&A session. Would you like to be the MC and facilitate the questions from the audience?
Yes, absolutely. Thank you so much, Jeffrey. Fantastic presentation as always. Really, really enjoyable. And I think you can see by the comments coming in there as well, it's very well received by our illustrious audience today. Guys, we are going to go into the Q&A. As Jeffrey said, we have about 10 minutes for questions. So it would be great if, looking at the Q&A panel, if there's any ones you want to see prioritized, you can upvote, and how I'll run it is whatever questions have the most votes for them, I'll prioritize those. And just a quick note as well, this is part of the Critical Crisis Thinking ISQua Learning Journey on the fellowship program. It's part of Module 3. Modules 1 and 2 are available now. Module 3 will be available later this week. So if you'd like to access this course with material like this, plus lots more, please feel free to sign up to the ISQua Fellowship Program. Okay, Jeffrey, we'll kick things off. So our first question is from Lucky. How can we make a model for crisis considering the complexity in healthcare? Looking at the current COVID-19 crisis, is it wise for healthcare institutions or countries to do a model or forecasting for further possible crises similar to it?
So the answer to your question, thank you for the question. The answer to your question is embedded in the question itself. You asked, how can we be prepared, and how can we deal with the complexity? And then you mentioned the word model. So you can do modeling. Many people do. And I think that, though, often we see the end of a pandemic or a crisis, and then we sort of pull ourselves out of that and think, wow, isn't that great? We've gone back to normal. And they kind of relax. I think modeling the complex ecosystem with, if you're sophisticated, you can do things like systems dynamics modeling. There are whole papers and books on that, which help to model the system and then say, if we put a crisis into this system, how's it likely to react? The other way is to do simulation. The military is very good at this, for example. You simulate a major crisis or a war, and then you say, okay, what have we learned about that? You can use the resilience assessment grid that I mentioned about monitoring and anticipating and learning and use those sort of devices as ways to structure your thinking. I'm a great fan, incidentally, of extrapolating from good data and then poking the data and saying, what would happen if, doing if-then type modeling thinking. Other colleagues in the Resilient Healthcare Net are really good at simulation. Say, in a crisis, the time to be encountering the crisis isn't the first time I've ever encountered it. It's when you do that offline and think, if this happens, what am I going to do? That kind of thinking. So I think modeling, simulation, systems dynamics modeling, extrapolation of data, and thinking through how prepared are we, almost putting yourself on a footing, and also thinking what are the unknown unknowns that might bite us. These are all good things to do.
Excellent. Thank you, Jeffrey. Great answer. Our next question is from Ricardo. We've always been told that money is not the answer to crisis management, in that we cannot expect to throw money into different areas to cope with the crisis, and we have to work smarter. How do we model this in a resilient health model?
Again, you can do that with something like systems dynamics modeling, where you can say, if we're doing a lot of work in the health system and we suddenly have to do more, what will be the likely effect? There's a couple of ways you can do that. You can do that with data, Ricardo. Incidentally, that's the Ricardo that I mentioned so favorably, who's working with us on all this work on Italy and Australia, and ISQua's learning from people about how they're coping with the pandemic. But the other thing you can do is put, even if you're not in a resource-rich society, you can put more resources when the crisis comes on into the crisis. So, of course, some countries are relatively much more wealthy, much more fortunate than others. Australia, for example, when I gave that example during the asthma thunderstorm, has a functioning health system. It has an ambulance system that works fantastically, and it was able to put resources into emergency departments that other countries probably are not fortunate enough to have. But there's a relative advantage, absolute wealth, but also there's whatever wealth you have, whatever income you have, whatever resources you have, to deploy them in the right place. And many times, less resource-rich countries and health systems don't put the resources in the right place sometimes. I mean, all health systems have that problem. So you can relatively fund some things that are needed at different times in the cycle of a crisis. Thank you.
Excellent. Thanks, Jeffrey. Our next question is from Tesfaye, who said, Dear Professor Jeffrey, what are the approaches of critical crisis thinking in poor resource settings? So I suppose we touched on that a little bit there.
So I started to touch on that, but just let me address that more clearly. Look, sometimes low resource settings have some advantages. Sometimes in high resource settings, and we're writing a paper on this, it should be published in a couple of weeks actually, several of us in the ISQua Academy. Sometimes high resource settings have spent a lot of money, for example, on very large, clunky IT systems. In some low resource settings, what you get is lots and lots of people with a mobile phone and great facility to be able to communicate fast on the ground. So while they may not have in low resource settings huge hospitals with MRI scanners and everything that goes ping, and a massive information system with an electronic medical record, for example, you can make best use of the smaller amount of resources you have and the nimbleness that can create. So, a very good colleague of mine who runs a health system said to me, and this is in a high resource setting, once the crisis kicked in, we just threw the rule book out of the window and did as best we can. Now, in some low resource settings, you can do that much faster than this person in a high resource setting and actually be more nimble and actually tackle some of the issues there and then locally. Thailand, the example I gave in Thailand was a good example where they train nurses to go into rural settings and talk to people about distancing and talk to people about, a 2-meter rule or a 1.5-meter rule and talk to people and offset the misinformation that might otherwise occur. So you can do a lot with not much sometimes and make the best of what you got.
Excellent. Thanks, Jeffrey.
In fact, we see that all the time.
Brilliant. Our next question is, can this model be applied at organizational or department level to assess resilience?
Yes, the resilience assessment grid is actually well used, and we've got lots of chapters in the resilient healthcare books, which Eric and I co-edit. In addition, there's quite a lot of papers and materials now on case studies of using the resilience assessment grid. Sometimes it's called the resilience analysis grid, to assess and build your capability for dealing with problems at organizational level and at systems level. So for sure there'll be a paper or a case study using the RAG, the resilient assessment grid, on a problem of the kind that you face, because there's quite a rich growing literature in that area.
Excellent. Thanks, Jeffrey. And I think we have time for one more quick question. Hagar has asked, if crises are considered unprecedented, then it implies that there can never be adequate preparation. Resilience, therefore, is the key to deal with crises. Your thoughts on this? Yeah,
I think that's absolutely right. My only problem is with that, I'm not arguing at all. It's great, Hagar, but resilience is not, it's necessary, but it's not enough. So you can be as resilient as you like. A big crisis is still going to roll you over if you don't take the relevant action at the relevant time. And we say in this program, this education program, the best thing you can do is really have done very high quality thinking using all the cognitive and thinking skills and tools that we're talking about at your disposal to really think long and hard and be prepared and able to predict. Because, it's just not a matter of if there's going to be another crisis. It's a matter of when. I gave 3 from Australia, but you could give lots from your own country too. The pandemic is only the most recent global crisis that we face. There's lots of others all the time.